Assalamu alaikum. Good evening, all of you. My name is Dr. Avais Abbas, and it's a great opportunity to talk to all of you. And today, the topic of my discussion will be basics of mechanical ventilation. I'll try to sum up all the basic concepts within 30 minutes, 40 minutes, inshallah. So, so coming to the objectives of today's presentation. We'll go through a few definitions first. After that, we'll discuss what are the indications of mechanical ventilation. After that, we'll discuss the basic concepts of mechanical ventilation. How do we apply settings on a mechanical ventilator? How do you monitor a patient who is on mechanical ventilator? And we'll discuss a bit of troubleshooting as well, not very complex. Then at the end, we'll discuss how do we perform liberation from mechanical ventilation, or how do we perform extubation from mechanical ventilation. So so let's see the concept of mechanical ventilation versus normal ventilation. By the word or the term normal ventilation, I mean the way or the mechanism through which we breathe normally. Right now, the mechanism through which I am breathing or you are breathing normally. So that is the mechanism. We call it negative pressure ventilation. By that, I mean it starts from the descent of the diaphragm. Our diaphragm actually comes down, and that creates a negative pressure in the intrathoracic cavity. So the atmospheric pressure is zero, the intrathoracic pressure is negative. So from zero to negative, this is the pressure gradient through which then the air travels through our mouth and enters into the lungs. So this is the normal mechanism of breathing. Nowadays, almost all the ventilator modes are operating on the basics of positive pressure ventilation, in which diaphragm descent is not the first step. A ventilator actually pushes air into our lungs directly. So ventilator is at a higher pressure, and our intrathoracic pressure is zero. And ventilator pressure, let's suppose, is maybe like 12 or 14 or 15. So that is 12, and in intrathoracic is zero. So through that gradient, the air moves through the circuit into the patient lung. So this is like pushing air into the lungs. So this is called positive pressure ventilation. So these days, almost all of the ventilators actually work on this principle of positive pressure ventilations. So now we'll discuss indications of mechanical ventilation. The most common indication of mechanical ventilation is the respiratory cause or respiratory system, that is apnea or respiratory arrest. Cardiac cause is also one of the most important, very frequent causes of initiation of mechanical ventilation, that is cardiogenic shock or cardiac failure. Neurological causes, post anesthesia, we need mechanical ventilation in cases of head trauma, in cases of coma, or in cases of neuromuscular failure. So these are the indications of mechanical ventilation from all the three important systems: respiratory, cardio, and neurology. So now coming to the basic concepts of mechanical ventilation. Now I'm sure all of you are familiar with this picture. This is a picture that you have seen throughout your graduation days. This shows the inspiratory and expiratory capacities and volume of the lung. Okay, so I'll quickly go through that. You can see this distance, the distance between these two lines, it is called tidal volume. Tidal volume is the volume of air that goes in and comes out with each breath. This is called tidal volume. Okay. Here, the term is inspiratory reserve volume. So on top of tidal volume, if you inspirate forcefully, then you will be able to add some more volume into the lung. Okay. So if you inspirate forcefully, so you will have, at the end of inspiration, you will have some extra added volume other than the tidal volume. So that is called inspiratory reserve capacity. And if you add both of these, the tidal volume and the extra inspiratory air that you have accumulated with extra effort, if you add both of these, it is called inspiratory capacity. Okay. Now coming to this was IRV was forceful inspiration. Now at the end of normal expiration, if you expirate forcefully, if you try to blow out air forcefully, you will be able to take out some more air from lungs. That is called expiratory reserve volume. It is also mentioned down here. Expiratory reserve volume. And even after forceful expiration, a bit of air is remaining in the lungs. That is called residual volume that you cannot expirate. Okay, so that will remain in the lung to keep alveoli patent. Okay, so if you add respiratory reserve volume plus tidal volume plus ERV, expiratory reserve volume, the sum is called vital capacity. And if you add expiratory reserve volume plus the residual volume, it is called FRC, functional residual capacity. And if you add all of these volumes, it is called TLC or total lung capacity. Now we'll discuss a very important equation. This is called equation of motion. Okay, so equation of motion says that ventilation pressure is equal to elastic pressure plus resistive pressure. In other words, the pressure that is needed by the ventilator to inflate the lungs or to deliver tidal volume is a sum of elastic pressure. That means that ventilator has to fight the elastic pressure that is there in the lungs plus the resistive pressure that is there in the lungs. So elastic pressure is there that is to inflate the lungs and chest wall, and resistive pressure that the ventilator has to fight is this resistance is given by the airways. So ventilator has to fight both of these pressure, the elastic pressure provided by the lungs and chest wall and the airway resistance. If ventilator is able to overcome both of these, then ventilator will be able to inflate the lung or bring a change in the volume of the lungs or give some tidal volume to the lungs. Okay. So, so again, one more thing. If elastic pressure increases or if the resistive pressure increases, then ventilator will have to work extra, okay, to generate the same tidal volume. Now, down here you can see there's an equation. Pressure is equal to volume divided by compliance plus resistance into flow. Okay, so this equation shows that more pressure is needed by the ventilator, or more force or more effort is needed by the ventilator to inflate the lung if scenario number one, the lung compliance decreases. Means if lung becomes stiff or lung becomes less compliant, then ventilator will have to work extra to create the same tidal volume. Okay. And second is more pressure is needed by the ventilator to inflate the lung if the resistance increases. Okay. So in cases of asthma or bronchospasm, there is more resistance. So ventilator now has to give more positive pressure or make more effort to bring change in the lung volume or to inflate the lungs or bring change in the tidal volumes. Okay, so lower the compliance, more effort is needed by the machine. Higher the resistance, more effort is needed by the machine. Okay, coming to the mechanics of breath. Okay, so these are like a few terms that are not very difficult to understand. So I'll go through one by one quickly and I'll try to make them easy for you. The first mechanic of breath is trigger mechanism. Second is limit variable. Third is cycle mechanism. By trigger, so these three mechanics apply on each single breath, each and every breath. For a breath, there must be a trigger, number A. By trigger means that there should be somebody who starts the breath. Either it can be patient or it can be machine, number one. Okay, so either machine will start the breath or either patient will start the breath. Number two, limit. By limit means there must be somebody which limits the inspiration. That means that inspiration is completed now. So who will limit the inspiration? That this much of air has already gone into the lungs. Now it's time to stop inspiration. So who will limit inspiration? Either machine can do or patient can do. The third is cycle mechanism. That means there must be someone who switches from inspiration to expiration. Either machine can do this cycling or the patient can do the cycling. So these three mechanisms that start from triggering the breath, then limiting the breath, then cycling the breath. These three can be done either by the machine or either by the patient. Now, Coming to the modes of ventilation. So this slide is very simple, and I've tried to actually make it very simple just for mere understanding of all of you. So three basic modes of ventilation. One is controlled mechanical ventilation. In bracket, I've written full control. In this mode, all the control, or by all the control, I mean trigger, limit, and cycle. All of these are by mechanical ventilator, are controlled by the mechanical ventilator. Okay, this is fully control mode. Patient doesn't have anything. Patient cannot do anything. Number two, the most commonly used mode is SIME, synchronized intermittent mandatory ventilation. As the term indicates, synchronized intermittent mandatory. It means that there are always two parties. One party is machine and the second party is the patient. Okay. So now if you apply this mode, if you start running this mode or operating this mode, now now the machine will synchronize with the patient's efforts. Okay, and will give leverage and will give margin to the patient to breathe as well if the patient is able to breathe. Okay, so this is a synchronized mode in which there is intermittent mandatory ventilation and intermittent patient ventilation. The word mandatory means the ventilation from the machine. Okay, and the word spontaneous means the breaths or breathing from the patient. Okay, so mandatory is from machine, spontaneous is from patient. So in SIMV, both of these breaths are there, and machine can also give breath, and patient, if patient is able to breathe, patient can also take a breath. Okay, the third is spontaneous modes in which most of the control is with the patient, very minimal control is with the machine. Okay, so there are two modes, pressure support ventilation, and one is CPAP mode. That can be a non-invasive mode as well, but for you just remember pressure support ventilation. We also call it spontaneous trial mode. Okay, so these three are the basic modes through which we actually most of the time we operate these three modes. Okay, now coming to the types of ventilator breaths. So there are three types of ventilator breaths. Okay, before two slides back, we are discussing the mechanics that are associated with each and every breath. Now we are discussing the types of breaths. Okay, so don't confuse these two slides. Okay, now types of breath. The first breath is mandatory. As I mentioned, the word mandatory means totally controlled by the machine. So in mandatory breath, trigger is by the machine, limit is by the machine, or cycle is by the machine. So only machine will trigger, machine can limit, and machine will cycle. Okay, this is a mandatory breath. Okay, in assisted breath, patient can also trigger, but patient can only trigger. Patient cannot limit the breath and patient cannot cycle the breath. That means limit and cycle will be by the machine. M is for machine. And spontaneous breath, these all mechanics, triggering will be by patient, limiting will be by patient, and cycling will be by patient. Okay, so these three are the types of breath. Okay, the like if the patient is paralyzed with the drug, okay, then all the breaths will be mandatory breaths. Like then because patient is paralyzed, so he cannot trigger, cannot limit, he cannot cycle. So all the mechanics will be controlled by the machine. And vice versa, if the patient is awake and making his own breaths really nicely, so all these three mechanics will be controlled by the patient. Okay, coming to the definition of minute ventilation. So we all know, I'll go by this definition very quickly. So minute ventilation is a product of tidal volume multiplied by respiratory rate or breathing frequency. Okay, tidal volume is the sum of dead space ventilation plus alveolar ventilation, and respiratory rate is the number of breaths per minute. That is a combination of inspiratory time and expiratory time. So that's a very simple concept. Okay, so coming to the advantages of all of these modes. So just before I discuss this slide, I'll just give you a very easy concept so that it make it easy for you to understand this slide. Okay, the higher the control is with the machine or the ventilator, okay, so the less will be the use of patient's muscle. Okay, the higher the machine control will be, the higher smooth and guaranteed the breathing will be. Okay, so coming to the CMV mode, controlled mechanical ventilation, that means this mode has all total breathing and all these mechanics, three mechanics being controlled by the machine totally. A patient has no input in this mode. In CMV mode, everything is controlled by the machine. So advantages are there is no interruption in ventilation because machine works perfectly, right? But the disadvantages are because patient cannot breathe, patient cannot use his or her muscles, so there will be disuse atrophy of the respiratory muscles. So in assist control mode, patient can only there are assisted breaths. Okay, so patient can only trigger the breath, but patient cannot cycle or limit the breath. Okay, but the advantages will be reduced work of breathing compared to spontaneous breathing because ventilator is still like playing the major role here. Okay, and potential adverse effect would be hemodynamic effects may lead to inappropriate ventilation because patient is awake and able to trigger, but patient cannot control. Patient can trigger but cannot control the whole breath. Okay, so if so, this potentially can cause asynchrony with the machine. Coming to SIMB mode, in which both breaths are independent and patient can control his own breath, control his own tidal volume, and machine gives his own its own breath. Okay, both go intermittent and both go synchronized. So this mode has an advantage that it creates less interference with normal CVS function, but the disadvantage can be that if the patient is not prepared for spontaneous breathing, so that will result in increased work of breathing. Okay, coming to pressure support ventilation or the spontaneous trials. So this mode has got the most patient comfort, improved patient and ventilator interaction. Okay, but disadvantages as is that the if patient is not ready or patient becomes apneic, so patient this mode will be discontinued. But thankfully there is an apnea alarm in the machine, so ventilator will switch back to mandatory breaths. Okay, so these are the advantages and disadvantages briefly of all these four modes. Now coming to the settings, the first thing that we do, so for example, now most commonly we use the SIMV mode, which is pressure controlled. Okay, so I'll discuss the settings of pressure control SIMV mode, that how do we set the ventilator according to that. The first thing is mode, second is respiratory rate, then pressure control, pressure support, trigger, I time, P, FiO2 and tidal volume. Okay, so coming to settings, so mode, so we select SIMV and the other options are control ventilation as well or spontaneous ventilation. But for example, if you're selecting SIMV, then there are two options, either select pressure control or volume control. That means in SIMV mode, if you select the pressure, then you can control the pressure that is delivered to the lungs, but you cannot control volume. The other way around, if you select volume SIMV, that means that you can control the volume or tidal volume that is delivered to the lungs, but you cannot control the pressure. Okay. So, for example, we select SIMV pressure control. Okay. Second setting is the respiratory rate. So, generally, when we start, most of the cases, we set the respiratory rate that is appropriate for the physiological age, for the patient's age. For example, he's a 2-year-old, the respiratory rate would be around 35 to 40 per minute according to his physiological age. But this is not always true. In different scenarios, we have sometimes to keep a bit high respiratory or a bit low respiratory rate. So I will not go into details of that. Okay, but just as a beginning concept, whenever you start ventilation, just set the respiratory rate that is normal for his age. Okay, and then you can change as per the PCO2 in the blood gas. Okay. So then you set pressure control and pressure support. So what is pressure control? The pressure control is actually the target that you give to the machine. Okay, and you say to the machine that the machine has to deliver this much of pressure inside the lungs. Okay, so if I keep a pressure control of 15, it means that I'm saying to the machine that machine, please develop a pressure of 15 in the patient's lungs. Okay, so case one, if I target a pressure control of 15, for example, machine. So how will the machine develop that pressure? The machine will develop that pressure by inflating air into the lungs. Okay, air and oxygen. Okay. So for example, if I set a pressure control of 15, let's say machine put in an air of 200 milliliter ml. Okay. If I increase the pressure control or increase the target to 20, the machine now probably will deliver 300 ml of air. Okay, so the higher the pressure control or higher the target you set, the more tidal volume the machine will give to the patient. Okay, so generally to start with, we set a pressure control of 20 and then we change it according to the appropriate tidal volume of the patient. Okay, that we keep generally 6 to 8 ml per kg generally. Okay, so this pressure control actually controls the tidal volume for mandatory breaths. Okay, keep this in mind. I'll repeat it. Pressure control manages the tidal volume for mandatory breaths. Pressure support, same function, same thing, but it manages the tidal volume for spontaneous breaths. Okay, and we start generally with 10 to 12, and then when the patient is awake and is making spontaneous breaths, so then we set according to the spontaneous tidal volume. Okay, so just remember the difference between pressure control and pressure support. Trigger sensitivity. So trigger sensitivity is a function that we have to actually set on the machine. So trigger is basically a target again that we set on the machine, and this target is for the patient. Okay, pressure trigger can be either flow or uh, pressure. Okay, either it can be flow trigger or pressure trigger. Okay, so for example, if this is, we keep it flow trigger. Okay, so if we set a target of 1 liter per minute of trigger on the machine, that means that we are setting a target on the machine for the patient, that if the patient wants to produce or make a spontaneous breathing effort, if the patient wants to breathe by his own, then patient will have to generate 1 liter per minute of flow in the tubing circuit during inspiratory phase. Okay, so when the patient will do inspiration, patient will pull some air from the tube into his lungs. Okay, so that pull of the air will create a flow. Okay, so that flow is measured. Okay, we have kept a target of, for example, let's say 1 liter per minute. So if that pull of the air, okay, pulling of the air, that creates a flow. If that flow at least hits the target of 1 liter per minute, that means the patient has matched our target, and patient now can trigger that breath, and ventilator will allow that breath to become to get completed. Otherwise, if the patient's inspiratory effort is weak and patient is able to inspirate, but the inspiratory power is very low, so patient will not be able to achieve a negative flow through the tube of 1 liter per minute. So patient is though able to inspirate, but patient will not match our target, and that breath will not be allowed by the machine to get completed. Okay. So this is the concept trigger. So in other words, the higher the trigger, the more effort will be required by the patient to complete that breath. Okay, so lower the trigger, the more easier for the patient to breathe. Okay, inspiratory time. So these are the cutoffs generally for different ages. So in some ventilators there is inspiratory time button. In some ventilators there is IE ratio button. Okay, so if there is IE ratio button, you set a IE ratio of 1:2. Okay, and if there is inspiratory time, then you manually calculate the breath cycle. Okay, and then um, give one time to inspiration and double time to expiration through setting this value. So PEEP, you all know what is PEEP. It is post and expiratory pressure. Generally, we start at 5 and 6, okay, and then we increase it according to the patient needs or patient's lungs condition. FiO2, that is needed as per the patient's condition, and tidal volume we generally target at 6 to 8 ml per kilo in normal healthy lungs. Okay, coming to the monitoring. Okay, so there are a few formulas through which we monitor patient's ventilation. One is SF ratio, that is saturation divided by FiO2. Normally, it is more than 250. Second thing is PF ratio. When you have got an arterial gas, blood gas, in which there is PO2, then it's better to calculate PF ratio. The normal ratio is greater than 300. And you can subsequently calculate these PF or SF ratios during the days of ventilation so as to monitor the progress of the patient. Okay. Third is oxygenation index, that is mean airway pressure multiplied by FiO2 divided by PO2. Normally, it is less than 5. The fourth thing that you can do is calculation of alveolar arterial gradient, that is the gradient between the alveolar oxygen content and the arterial oxygen content. Okay, how do you confirm an ETT placement? So there are many things, many ways through which we can confirm. First is there is air mist in the ETT. Second thing, you can see the chest rise through the bagging. Third is you can auscultate the chest through a stethoscope and you can confirm the ETT placement, that is it is correctly placed into the trachea. Fourth is you can get an X-ray chest. Okay, fifth is you connect the end-tidal CO2. That is a device that measures the exhaled carbon dioxide. So these are some devices are disposable devices that contain litmus paper that changes the color, and some devices are reusable that are connected in the ventilator that actually show the graph and a number of carbon dioxide, exhaled carbon dioxide. Okay, this is the disposable EtCO2. And one more method is direct laryngoscopic visualization. That is the most probably the most authentic method. Okay, so capnometry. Capnometry is the quantitative measurement of CO2 in the exhaled gas that I just talked about. Okay, so when the tube is in trachea, definitely exhaled gas will come out of trachea and there will be some CO2 detected. Okay, if CO2 is not there, that means you are not in the trachea. Okay, so capnometry is the measure of exhaled CO2. Coming to the troubleshooting. Okay, so troubleshooting can be patient related, can be from abnormal alarms, and can be an abnormal blood gas. Okay, so in all the cases, okay, you must remember one line of action, that is dope. Whenever there is a trouble in a patient who is being mechanically ventilated, there is a trouble in mechanical ventilation, you have to follow dope. Okay, all of the word, this is being followed. So the first thing, D, is displacement. You have to see whether the tube is in the place or it is displaced. You see the fixation of the tube. For example, it was fixed at 15 centimeter. Now what is the fixation? It is now at 12. Maybe the tube is out. Okay. Second, you see obstruction. If the tube is in place, then you see if the tube is obstructed or not. Maybe, so if the tube is obstructed, so maybe patient needs a suction. Okay, and after that tube is cleared and the things are correct again. Okay. Third thing is spontaneous development of pneumothorax. Okay, so there is a clinical suspicion. You can get a suspicion of pneumothorax on clinical examination. Abnormal chest rise. Okay, no chest rise on one side where patient has probably developed pneumothorax. Okay, you can get an X-ray chest quickly. You can auscultate. Okay, and on these basis you can take a decision. So third thing is you check for pneumothorax whenever patient, mechanical ventilation starts troubling you. So displacement, obstruction, then P, pneumothorax. And if these three things are okay, then you consider there might be some problem with the machine or equipment. That includes machine, that includes filters and the tubing till the ETT. Okay, this is the four things. These are the four things that you have to check all the time or anytime you face any trouble during mechanical ventilation. But one suggestion, whenever you start checking for displacement, even before D, I suggest that just see the screen of the ventilator and see whether there are any tidal volumes are there or not, and see the capnometry graph so that you will get an idea. So the first troubleshooting is high pressure alarm. So alarm limits are generally set 5 to 10 centimeter above the peak inspiratory pressure. So there are two types of pressure. One is peak pressure, that is called P peak. The second pressure is P plat or plateau pressure. Okay, what is P peak? So I'll make it simple for you. Peak pressure on the ventilator is the pressure developed in the lungs at the end of inspiration, and this pressure includes the pressure that is there in the alveoli plus that is there in the airways. Okay, so this is called peak pressure. And plateau pressure, a bit different from that and a bit lower than the peak pressure. So plateau pressure is the pressure developed in the lungs at the end of inspiration, same like peak pressures, but these pressures include only the pressures that are developed in the alveoli, not the airways. Okay, so that is the difference. Okay, so definitely peak pressures are a bit high than plateau pressures. Peak pressures generally 4 to 5 centimeter H2O higher than the plateau pressures, as you can see in the diagram as well here. This is the peak pressure and this is the plateau pressure. How do we check plateau pressure? There is a button in the ventilator that is called inspiratory hold. Okay, so when you press inspiratory hold, so machine hold after complete inspiration, machine holds the breath a few seconds and calculate the plateau pressure. Peak pressure is coming on the machine already. Okay, so there can be one of these two scenarios. Okay, so one scenario can be in the case of high alarms. I'm talking about in the case of high alarms. Okay, so one scenario can be both high peak inspiratory pressure or high P peak, okay, and high P plat. Scenario number one, both peak pressures and plateau pressure are high. Scenario number two, peak pressure are high, but plateau pressure is same. Okay, so in scenario number one, so for example, before this problem happens, you have got the values of peak pressure and plateau pressure before that during the normal phase. Okay, now the ventilator starts troubling you. You see both of these values again. Okay, you have the previous values written. Now you check peak pressure again and plateau pressure again. Okay, if you see that peak pressure has increased from the previous value and plateau pressure has also increased from the previous value. Okay, and so the difference between P peak and P plat is the same. Okay, P peak minus P plat is no change. So that means the lung compliance has got worsened. Okay, so lung compliance has worsened. Okay, so that means lungs are getting more diseased, more stiff. Okay, so this is the interpretation of that. Scenario number two, if you check during the problematic phase, if you check P peak and P peak has increased, but P plat is same. Okay, so that means P peak minus P plat, the difference between these two would be increased. Okay, so the interpretation of this scenario is there is some airway obstruction, either secretions are there or either bronchospasm. Okay, so if you do this bit of exercise, this is not a difficult exercise, just take a couple of minutes at the bedside. If you do this sort of exercise, this can be very helpful in determining what's the actual cause of the deterioration that you are facing right now. Okay? So there are some alarms of high PEEP or auto PEEP or intrinsic PEEP. The causes can be high tidal volume, and you can troubleshoot by decreasing the tidal volume. If patient is having bronchospasm, patient needs bronchodilators. If there is high I time, you can decrease I time. Okay. So these are the causes of high PEEP alarm and the troubleshooting as well. Okay, if the alarm is there of high tidal volume, so one interpretation can be the lungs are getting better or lungs compliance is getting improved. So you can, the troubleshooting is you can come down on the tidal volume or come down on the pressures or pressure control. Okay. Second cause can be expiratory limb blockage or filter choking. You have to change or wash filter. External nebulizer is attached. When nebulizer is attached, so that results in high tidal volume alarm. If the patient is auto triggering, patient is triggering more than required, so that also can create high tidal volume alarms. And if the alarm setting is too low, so then also there will be alarm and you have to adjust the alarm. So these were the high pressure problems. Okay, coming to the low pressure alarm. Okay, so the causes for low pressure alarm. Okay, it can be ventilator disconnection. It can be secretions. If there is disconnection, you have to reconnect the circuit. In cases of secretion, you have to do suctioning. In case of bronchospasm, you have to give bronchodilators IV or through the puff. Okay, the what do you call it? Either through nebulizers or through the inhalers. Okay, if the patient is tachypnic, so one cause can be tachypnea. Okay, if the patient is awake and patient is still tachypnic, that means the patient is not ready to be weaned. This is a premature weaning. Okay, if there is leak in the atrial circuit, it can also cause low pressure alarm. Other than that, worsening lung condition can cause low tidal volumes. Okay, and low pressure alarms. Kinking or ETD biting, inadequate flow, and inappropriate alarm setting. These all are the causes of low pressure alarm, and you have to troubleshoot accordingly. Okay, one alarm is apnea alarm. That is there in the in every ventilator, and that is a safety alarm. So whenever you put a patient on spontaneous breathing trials or pressure support ventilation, same both are same interchangeable words. So if the patient, for example, God forbid, develops apnea in between that, okay, the ventilator will start backup breathing. Okay, just to so it's a safety measure. So two abnormalities now in the blood gas. Okay, we discussed high pressure alarm problems, we discussed low pressure alarm problems, and now we're discussing abnormalities in the blood gas. Two common is high PCO2 and low PaO2 in the blood gas. So high PaCO2, high carbon dioxide content of in the blood gas. So causes can be secretions, you have to do suctioning. Causes can be bronchospasm, you have to bronchodilate. Okay, cause can be decreased thoracic compliance or worsening lung condition. So you have to then change the ventilation strategy or modify the ventilation strategy accordingly. If ventilator disconnection is a cause, you have to reconnect. If ETT is being bitten or being is kinking, you have to correct that, and you patient might need an oral airway or some added sedation so that patient is well sedated and does not bite the ETT. If there is leak in the ETT circuit, you have to inflate the cuff or check the patency of the circuit all over again. Coming to hypoxemia or low PaO2, so hypoventilation can be a cause. You have to increase the minute ventilation. If FiO2 is low, then what patient requires, you have to increase the FiO2. Okay, if the lung condition is worsening, then you have to increase the PEEP and adjust the ventilator settings. Okay, and if these all problem persist despite you have made all the required changes, then probably patient needs an advanced mode of ventilation, that is the HFO that we use in refractory cases. Okay, so you have to disconnect patient from the ventilator only in the cases of respiratory distress or refractory desaturation, and then you have to bag manually. Okay, do not disconnect the patient's ventilator frequently, particularly in the patients who are on high PEEP. Okay, coming to the last bit of the presentation. So that is liberation from mechanical ventilation. How do we extubate? Okay, so there is a criteria, we call it CALMS criteria. Okay, this is a checklist that we go through before we extubate a patient. Okay, so in CALMS, C is for CNS, that we check alert or good mental status, good cough and gag reflexes, so that patient can cough, and good cough and gag means a patient can have can protect its airway from the secretions, from the saliva and from the secretions in the respiratory tract, and patient is able to cough and take out those secretions, or in the other words, patient can handle those secretions. Coming to airway, C and then A is for airway. That means we have to check for upper airway edema that happens after few days of intubation. So if there is upper airway edema, so that's not an absolute contraindication for extubation, but then we have to be cautious. We have to use cold saline nabs and epinephrine and all that, because you will expect some stridor post-extubation. L is for lungs. So you have to see the status of lungs. Lungs are healthy enough that the patient can be extubated. Fourth is M for muscles. You have to check for absence of neuromuscular weakness. The respiratory muscles are strong enough that patient can sustain post-extubation. And the fifth thing is secretions. You have to see the quantity and quality of secretions. If the quantity is significant, also you have to be very cautious before extubation. And if the quality of secretions are changing, that means patient might have developed a new infection. Okay, so you have to be cautious of that. Okay, and also ask from the nurses, what is the frequency of suctioning? If the frequency of suctioning is increasing, so again, you have to be cautious regarding extubation. So coming to the spontaneous breathing trials, SPT. Okay, that is a pressure support ventilation. So generally we start trial from 30-minute duration. We can extend it to 1 hour or 2 hours maximum generally. So either this can be like two-way. Either patient will tolerate that spontaneous trial, or a patient will not tolerate the spontaneous trial. Okay, so it can be given via two ways. One is through the ventilator, that generally we call spontaneous breathing trial, or the pressure support ventilation. Okay, one trial is through the T-piece. Okay, we disconnect the ventilator altogether and we just connect the T-piece and we attach oxygen to that. The difference between T-piece and spontaneous trial is that in spontaneous trial there is some pressure support. Remember, I discussed pressure support, concept of pressure support, the pressure that augments the tidal volume for spontaneous breath. So in pressure support ventilation, there will be some pressure support that will be helping the patient's tidal volume, but in T-piece trial there will be no pressure support. Okay, what are the signs of spontaneous trial failure? First is change in mental status. If patient is getting anxious, agitated, comatose, or sleepy or drowsy, that is one sign of spontaneous trial failure. Second, the other common sign is signs of increased work of breathing. If patient has started developing nasal flaring on spontaneous breathing trial, or tachypnea, or low tidal volume, frequent breathing, paradoxical breathing, or use of accessory muscles, if you are watching that, that is a sign of failure of SPT. So that means the patient is not prepared for extubation. Give him some more time. Okay, third thing is hemodynamic stability. If the patient has become tachycardic or hypertensive or less commonly hypotensive, that also means that the patient is not ready for extubation. Precautions that we take before extubation is that we have to keep patient NPO for 4 hours for liquids and 6 hours for solids. We have to empty stomach just before extubation. We have to suction the airway one last time before we extubate. We have to deflate the cuff sometime before we extubate. And we have to prop up the patient so that we minimize the chances of aspiration. Okay, and how do we prevent upper airway edema? We give steroids, we can give epinephrine neffs, and we can give cold saline neffs. We have a limited time, so this was all from my side, and thank you so much. Thank you very much for all the time and your concentration. Thank you so much. Goodbye.